The next topic is the gastric cancer treatment. There is the Etoh guideline by Professor Tsuyoshi Etoh. Professor Tsuyoshi Etoh is chairman of the Japanese Laparoscopic Surgery Study Group, and right now he is professor at the Oita University Faculty of Medicine. He graduated from the Oita University and finished the PhD in the Oita University. Please, Professor.
Good morning, everyone. Thank you very much for a kind introduction. My name is Tsuyoshi Etoh from Oita University, Japan. First of all, I'd like to sincerely appreciation to invite me for the Professor Bitun and President Kitano and the chairman. And thank you for the great support for me, Olympus staff and the Mesda staff. Thank you very much. Today, I have two talks. The one is the introduction of the Eastern guideline, Japanese guideline, and the other is the technical tips of laparoscopic minimal invasive gastric surgery. Okay, let me talk on the first topic. First topic is the current status of gastric cancer treatment, especially in the 7th Japanese gastric cancer treatment guideline. This guideline is very recently published this year. This slide shows the history of Japanese gastric cancer treatment guidelines. The first guideline was published in the 2001, and then we have the 6th edition. And this year, we had the 7th edition, 2025. These guidelines are based on the Japanese and the global evidences. This slide shows the algorithm and the standard treatment for gastric cancer. As for the early gastric cancer, our previous speakers introduced the indication or treatment for early gastric cancer. And adjuvant chemotherapy or perioperative chemotherapy was already talked in the previous speakers. And today, I'd like to talk about the surgical treatment, especially in the minimal invasive surgery. Our guidelines contains as follows, shown in this slide. The first preface the treatment guideline, and the next the treatment in detail: surgery, endoscopic resection, systemic chemotherapy, and adjuvant chemotherapy or palliative care, and so on. And the clinical question. The question included 41 issues. So I'd like to focus on the clinical question in minimal invasive gastrectomy in the latest guideline. This slide, this photo is the first case of laparoscopic gastrectomy for early gastric cancer in 1991, operated by President Kitano. So this is a memorial photo for us. So far, we have the many global evidence of lap gastrectomy for gastric cancer in terms of the short-term and long-term outcomes, mainly from Japan, Korea, and China. So far, we had evidence of the technical feasibility and oncological feasibility of the early gastric cancer. And then we have already evidence for early gastric cancer, and early gastric cancer is already standard treatment of the lap gastrectomy, minimal invasive surgery. But the next question was whether this procedure was feasible or not for advanced gastric cancer. So is lap gastrectomy, the question is lap gastrectomy recommended for clinical 2 or 3 gastric cancer? So previous version is no clear recommendation because of the lack of the solid evidence. So this edition, the change. So lap gastrectomy for clinical stage 2 or 3 gastric cancer is now strongly recommended treatment in the lap distal gastrectomy. I'd like to introduce my our clinical trial from Japan, JLSH0901 study. This study of the PI is President Kitano, and I am the Secretary General of this study. This study, in this study, there are 507 patients enrolled and assigned to open or LADG port. This is a result of the primary endpoint, 5 years relapse-free survival. As you can see, we could prove the non-inferiority of lap gastrectomy for advanced gastric cancer compared to open gastrectomy, open distal gastrectomy. This content was already published in JAMA Surgery 2 years ago. This is secondary endpoint overall survival. You can see the almost same, but a little bit better of the lap gastrectomy compared to the open gastrectomy. Hazard ratio was 0.83. We Japanese minimal invasive doctors are very satisfied with the result. So far, we have the global evidence, not only Japan, but also Korea, China, as for lap gastrectomy for the advanced gastric cancer. So all RCTs successfully proved the non-inferiority of minimal invasive surgery. On the other hand, we have several strengths of our study compared to the Korea and the China study. The first is the primary endpoint was 5-year relapse survival in Japan trial, but Korea and the China trials, the primary endpoint was 3 years relapse free survival. And the follow-up rate is more than 99%, very strictly observation. And the crossovers, no crossover in the first analysis, and the detailed sub-analysis. So we confident that our study has robust evidences. And surgical quality was very important for such a clinical trial. In Japan have a unique certification system. ESSQS means endoscopic surgical skill qualification system. So this system was associated with a favorable surgical outcome or lap gastrectomy for gastric cancer. So most of the randomized clinical trial from Japan, JCOC study or our study, have used the ESSQS as a surgical quality control. So, what is the next clinical question? This next clinical question. Bulky metastasis or EGD cancer or more advanced gastric cancer, including type 3 or type 4 gastric cancer, and the preoperative chemotherapy patient, and the conversion surgery, and so on. The next question is the lap total gastrectomy recommended for clinical stage 2 or 3 gastric cancer. Our previous version is evidence C, and the now versions are also the evidence C, not changed. So now, some RCTs is going, including a JCOC study or KERA study, CERA study, and European studies. Let me introduce the Japanese study, JCOC study. This study, the purpose is to investigate the safety of robotic spleen-preserving spleen higher dissection for proximal gastric cancer invading the greater curvature side. The primary endpoint was incident of pancreatic fistula or abdominal abscess. In this trial, the enrollment already finished, and we are waiting for the result. Maybe this result will be open soon. The analysis is already finished. Maybe this data will be open in the ASCO the next year. The next question is the robotic gastrectomy recommended for gastric cancer. The previous version was evidence C and not changed in the latest version because of the insufficient the evidence for the robotic surgery for gastric cancer in Japan. However, the number of the cases of the robotic surgery is rapidly increasing in Japan because the robotic surgery has been covered by national insurance in the 2018. Since then, the number of surgeries is rapidly increasing, and maybe approximately 30% of the cases per total number was performed the robotic surgery. This is the global evidence of gastrectomy. The technical feasibility was confirmed, but the long-term outcome was not confirmed. So we are waiting for the result. So now in Japan, the JCOC study is ongoing. Lap surgery versus robotic surgery. The enrollment will finish in the next year. So we will be able to get the result in the next year. Primary endpoint of this study was incidence of the postoperative intraabdominal infection complication, not the long-term survival. And next question is minimal invasive surgery recommended for EGG cancers. This is a new clinical question in the latest version. Nowadays, the evidence is C. This is algorithm's surgical approach and the lymph node dissection of EGG cancer in the Japanese guideline, according to the tumor size or in the length of the tumor to the esophagus and the lymph node metastasis, clinical metastasis. The big concern of the EGG cancer surgery is the incidence of anastomotic leakage. Nowadays, around 10% was occurred, the anastomotic leakage. So that's a big problem at this moment in Japan. The next, minimal invasive surgery recommended for neoadjuvant cases for gastric cancer. This is also the new clinical question. And nowadays, evidence level is C. The global evidence of rapid gastrectomy for patients with NAC is not sufficient. So we are waiting for the result from the ongoing RCT. Now in Japan, the ongoing clinical trial of NAC for advanced gastric and EGG cancer by JCOC. This study is limited not only the open surgery, but also minimally invasive surgery. This study is including both surgical procedure. The regimen were DOS or FLOT. But the previous speakers mentioned the FLOT plus ICI is a promising tool. So this result is now rearranged in the JCOC study group. As for the minimal invasive surgery after the chemotherapy, so this is a retrospective, the prospective cohort study was ongoing. The PI with the study is Obama from Kyoto University, and the endpoint is morbidity. So we are now collecting data using by the National Clinical Database, with a big database. So for example, the distal gastrectomy will be enrolled 4,000 cases, and the total gastrectomy is 5,000 cases, big data. The last question is conversion surgery recommended for cases and went to chemotherapy. So now the previous version evidence D. So no clear recommendation because of the lack of the solid evidence, even in the open surgery. So, there's some chemotherapy with a dramatically effect for even to the stage 4 gastric cancer. So I have the experience of some good cases that a preoperative diagnosis of stage 4 gastric cancer. This patient underwent SP regimen, and then the downstage was established. And then I performed the conversion surgery in the open surgery. and arrows reduction, and pathologically showed no residual tumor, complete resection. And then this patient survived 10 years more. So this is a lucky case. So global evidence of surgery for stage 4 gastric cancer. This is a retrospective study from the Eastern Asia. So conversion surgery therapy could be a new therapeutic strategy to improve the survival of patients, especially those with R0 resection. So now, new clinical trial in Japan is ongoing. RCT of the conversion surgery for initially unresectable stage 4 gastric cancer. Nowadays, this study includes only open surgery, but maybe next year, minimal invasive surgery was accepted. Anyway, so we are now collecting the data, patient data, and we are we are waiting for the result in the future. So, can minimal invasive surgery give advantage for this tumor, this stage of the patient? It should be confirmed in terms of not only technical, but also the clinical oncological safety. For next version, we have to accumulate the solid evidence of the minimal invasive surgery for gastric cancer. Thank you very much for your kind attention.
Thank you very much, professors. So, for the questions will be let's do ask at the end of this session. Okay, let's move to the next topic.